Hello, thank you everyone for coming. I'm Dr. Aversano. It's wonderful to be able to present to everyone here on this topic. So today we're going to talk about elbow conditions in the adolescent athlete. The majority of these conditions predominantly affect throwers, but there are certain conditions that also affect other athletes, which we'll touch on briefly. So the main constellation of pathology that we're going to talk about is something called Little League elbow, and it can be a combination of injury to multiple parts of the elbow that is a result of primarily of repetitive stress on the immature skeleton in adolescent athletes. So patients can have inflammation and injury to the growth plate on the inner part of the elbow, the medial epicondyle. They can have strain or tear of the ligament on the medial part of the elbow. They can have avulsion fractures of that complex where the ulnar collateral ligament attaches either on the medial epicondyle or on the ulna. They can have muscle strains, muscle tears. They can have nerve injuries, nerve stress. And then there's also a constellation of symptoms which progresses over time called valgus extension overload, which is an impingement on the other side of the elbow that results from that stress as well. And then there are more acute injuries such as medial epicondyle avulsion fracture, where the bone actually separates from the growth plate. We briefly talked about the nerve symptoms that can happen. So that constellation of symptoms is called cubital tunnel, and that's the ulnar nerve on the inside part of the elbow becomes irritated from repetitive stress or strain. And then there can be cartilage injuries, so an osteochondral defect of the elbow, and that typically affects the capitellum portion of the elbow. So we'll touch on kind of each of these pathologies here in this talk. The primary cause of these injuries is a high pitch count in young athletes. Adolescents who have a higher pitch count and who have a higher velocity are more often associated with higher rates of elbow injuries, especially the ones that we talked about. So pitching greater than 8 months per year has been shown to lead to more elbow injuries, and then continued pitching despite pain or fatigue in the elbow predisposes patients to having injuries, whether they're chronic overuse injuries or acute injuries to the elbow. Just as some context of in the MLB, elbow injuries account for approximately 20% of all injuries to MLB players. So even on the mature athlete, that amount of stress can lead to injuries. So on the immature athlete, it's even more pronounced. So Little League elbow is due to repetitive valgus loading of the elbow from throwing, and this leads to microtrauma on the immature skeleton. Potential sites of injury are the medial epicondyle, that's the bony prominence on the inner part of your elbow. The ligament that attaches to that is called the ulnar collateral ligament, and then the group of muscles that attaches to that is called the flexor pronator mass, and that's what bends our wrist and rotates our forearm down. So in Little League elbow, typically patients will present with elbow pain in their throwing arm. It's typically a pitcher, but it can be other field positions as well. Often there'll be a prodrome of decreasing throwing speed, decreasing accuracy, decreasing distance that they're throwing over time, and it becomes more and more pronounced and more severe. When you examine the elbow, there's tenderness right on the inner part of the elbow over the bony prominence. At the medial elbow, there's pain with stressing the elbow, pushing it outwards. X-rays can show widening of the physis in that region, and an MRI can show inflammation of the physis or the adjacent bone, and that's the bright white area that's pointed out with the arrow on the slide here. So the bright white here, and then the ligament that attaches to it is called the ulnar collateral ligament, and we talked about how that can also get stressed, strained, or torn, even in a young adolescent athlete. So in addition to there being tearing of the ligament, which is demonstrated in this slide, there can be small little avulsion fractures where the ligament attaches on either side of the elbow. And then as this progresses, the other portions of the elbow can become stretched, strained, and actually degenerate. You can see bone spurs forming from the constant overload of the other side of the elbow and shearing forces on the other side of the elbow as this becomes more and more progressive with time. Treatment options for this constellation of symptoms. If we're able to catch it early before symptoms are too severe and the adolescent is able to rest appropriately, most patients resolve without any need for surgery. So it's typically a period of rest where the arm is completely shut down from any weightlifting, any sports, especially throwing, followed by slow progression back to activities and physical therapy to strengthen the muscles around the elbow and the forearm. When and if that fails, and as I said, most of the time in adolescents, we're able to successfully treat patients and get them back to throwing successfully without pain, without a surgery. But in certain cases, due to the amount of damage that's occurred or due to a more acute injury, surgery needs to be considered, especially in a high-level athlete who's planning to kind of continue to pursue high-level pitching or throwing later on in life. And operative options for these conditions are arthroscopic, typically when there's bone spurs or degenerative changes with the valgus extension overload syndrome, or if there's a ligament tear. Occasionally in an adolescent athlete, we even have to reconstruct that ligament if the tear is significant and the patient is a high-level thrower and wants to continue to be. But as I discussed, typically we are able to successfully treat these patients before it gets to that point of needing surgery. And the most important slide of this talk is this slide here, and it's on limiting the pitch counts and making sure that patients have adequate rest between days of pitching and throwing. And there's been a push over the last several years between the various different baseball organizations and the medical community to really educate coaches, educate parents, and educate athletes on these numbers. So these numbers are the recommended amounts of pitches that should be allowed daily and the amount of rest that should be allowed for young athletes who are pitching and throwing. And most parents of high-level athletes, most coaches, are aware of these now because there's been a lot of education put into this in recent years. Now, we talked about some of the kind of chronic or subacute injuries to the elbow that can happen with repetitive trauma over time, but you can have more acute injuries, and these can happen from a fall, and whether that's a fall related to sports or not, or a fall related to an awkward landing in a sport like gymnastics, you can have something called a medial epicondyle avulsion fracture, where that's actually that inner part of the elbow, that bony prominence where there's a growth plate, which can become irritated with throwing, can actually break off from the rest of the end of the upper arm bone, the distal humerus. And it can rotate, it can become quite displaced. And in a non-throwing athlete, these typically heal with conservative treatment, but if there's significant displacement in a throwing athlete, despite it healing, if you let it heal with too much displacement, it will decrease their ability to throw with force and speed regularly. So oftentimes in a high-level athlete where there's significant displacement of this fracture, we do consider surgery to optimize their outcomes and ability to continue their pursuit of sports. So the surgery for this injury, when there's significant displacement of that piece of bone, that fracture fragment, is to fix it typically with a screw. It's a minimally invasive surgery, but it is a surgery, and it does require a period of recovery, immobilization, and therapy after it oftentimes. I also touched briefly on how the nerve in that area on the inner part of the elbow can become irritated, stressed, strained from repetitive throwing. So occasionally, rather than patients complaining of pain, they'll also complain of numbness, tingling, radiating down their forearm, weakness in the hand. Symptoms worsen with progressive or sustained periods of throwing, or it can become to the point where other activities bother it as well. And that's called cubital tunnel syndrome. So the ulnar nerve tracks right underneath the medial epicondyle, that bony prominence, which sees all that stress with throwing, and that can become stretched, strained with throwing. And it can cause discomfort in that area or nerve symptoms. Typically, we are able to resolve those symptoms with a period of rest, splinting, education on avoiding ways to strain that nerve, physical therapy to strengthen the muscles around the elbow, and then a throwing program and progression back to sport. Rarely in an adolescent does that nerve need to be decompressed, but it is an option if symptoms persist despite an adequate attempt at non-operative treatment. And the last condition I want to touch on as it relates to this constellation of elbow symptoms is when the cartilage actually gets injured. And that's typically on the other side of the elbow where there's a compressive force rather than a tension force. It's usually a localized cartilage injury. Think of it like a pothole in the road rather than degeneration throughout the elbow. Oftentimes, if patients are able to come in early, it's able to successfully be treated non-operatively if the condition has not progressed to the point where the cartilage becomes detached or loosened. But unfortunately, sometimes it does get to that point. Typically, this is seen in pitchers or gymnasts. Those are the two sports where typically the strain is high enough or repetitive enough that this condition happens. When the different stages of this condition are initially, it's pain, and if the cartilage is intact, it can be treated with a period of mobilization and rest. If the cartilage becomes broken, loose, or collapsed, oftentimes surgery is required to treat this condition successfully and prevent further degeneration or damage to the elbow. So with intact cartilage, we can treat it with immobilization, rest, followed by progression back to activities. But when this becomes more severe, we have to start considering ways to repair or reconstruct that cartilage that's been severely injured. So there's a procedure called microfracture or drilling to stimulate healing in that area where the cartilage has been damaged. If this is typically done arthroscopically with a small portal sites and cameras in the elbow to poke small or drill small holes into the exposed bone, and that can stimulate formation of a type of cartilage to cover that exposed bone and repair that defect. If there's a loose body that's detached, that can cause mechanical problems in the elbow, so we can remove that. And if it's large enough, sometimes we'll fix it back into place with small screws or other mechanisms to fix it. But then if the piece of detached cartilage is not repairable and or large enough, we'll take cartilage from either a cadaver or the patient's own cartilage from another site in their body and implant it back into that pothole to fill that defect. Thank you.